Well, I think that's it's the appointed time, so I'm sure some more people will still filter in. But welcome everybody. Again, my name's Hugh Brewster. I'm located in Toronto from the home office, as many of us are experiencing, and we're delighted to welcome you to our 16th webinar on the principles of partnership with Jessica Fraser and Beatrice, who will be meeting in a second. And we're glad you're here.
Good morning.
Good morning. Go ahead, Niti. Oh, we're having a technical challenge here. Yeah, go ahead, Niti.
All right. Okay. Hi, everyone. Welcome and thanks for joining in. To begin with, I'd like to share some Zoom webinar tips that will be great for all of us to follow. We request you to please display your first and last name. It really helps us to know who we are interacting with. If you would like to display your name, all you need to do is simply click on the participants button and hover over your name, and then you will get the option to rename yourself, and you can just simply rename yourself and the display name will change. We will be muting your microphone while the presentation is on to reduce the background noise. You can use the chat feature to send across comments or questions while the presentation is on. Again, for those who might be new to Zoom, you have the option of clicking on the chat button that will appear at the bottom of your screen. And once you do that, you should be able to chat with people. And you also have the option of moving the chat box around. And it helps you to just keep the box on your screen, and you can keep track of the conversations and questions that are taking place at the time. After Jessica and Beatrice finish their presentation, we'll invite you to ask questions. You can type out your questions using the chat feature, or you can directly ask a question by unmuting yourself and switching on your video. Okay, so how are we going to proceed today? We will begin with a short COCP update, followed by the main presentation by Jessica and Beatrice. That will last for about 25 minutes, to be followed by the question and answer round for the remaining half hour or so. So overall, this webinar is planned for an hour. We also have a very interesting webinar coming up in 2 weeks' time. On the 25th of June, we have our first COCP panel discussion with Dr. Surat Subramanian, Dr. Olasanya, and Karen, all of who will speak about the use of speech therapy during the COVID era. So what are the objectives of the Circle of Cleft Professionals? Our aim is to facilitate networking and collaboration amongst cleft professionals to communicate impact and learning that's happening within cleft care, and that will in turn support the growth of local teams in implementing comprehensive cleft care. So we now have over 200 members in our COCP community belonging to 12+ specialties within cleft care, coming from 37 different countries across 5 continents. As you can see, a lot of our members are speech therapists, surgeons, and orthodontists, but you can also see that we have representation of members from across all other specialties within cleft care, such as nutritionists, social workers, nurses, and cleft care leaders. So a large range of experience there. These are the 37 countries that our members come from. The ones in green are the countries that we have the most membership from. That will be US, Canada, Chile, Argentina, Ethiopia, and India. But we're always looking at growing a community. So if you know someone who might benefit from or would be interested in joining COCP, please invite them to apply for membership through our website. We would like to thank our 10 charity organizations from around the world who are invested in supporting comprehensive cleft care in low and middle income countries. And I would now hand this over back to Hugh so he can introduce our lovely speakers for today.
Thanks, Niti. That's great. So We have been expanding beyond, and I'll invite you, if you are on not muted, if you could just mute yourself so we can all focus, it's great. We have been expanding beyond strictly Cleft topics. And as we know, Cleft care, especially partnerships between NGOs in places like Canada, the UK, United States, along with Cleft teams in low and middle income countries, is part of a larger development story of how we're reaching out to vulnerable communities and how we're trying to build sustainable solutions for those needs of people affected by Cleft. And so one of the organizations that's made a lot of progress, I think, in really helping us understand how to do partnership effectively is THET out of London, UK. And we're delighted today to talk a little bit more about these health partnerships. Jessica Fraser and Beatrice, both, as I've mentioned, have escaped the central of London off to different parts of the UK during this COVID-19 situation that we've all been talking about this morning. But from those remote locations, they've decided to join us, and they'll co-facilitate our discussion today on what that has learned a little bit about partnership and what that can mean for us as we think about, you know, some of the tensions, some of the changes, some of the creativity that's opened up in this COVID era for us to think about how we partner well and how we demonstrate these effective partnerships for Cleft Care. So without further ado, I'll pass it over from my home office here in Toronto to out in different parts of the UK, and feel free to share your screen anytime now, colleagues.
Okay, can everybody see my screen now?
It's looking great.
Yes,
great. I'll just pass
Well
over
done.
to my colleague Jess then, who's going to do the main presentation today. Thanks, Jess.
Great. Well, hello everyone. And just to check, everyone can hear me okay? Yes, okay, great. So hello, and it's a pleasure to join you all today. Thank you very much to Transforming Faces for inviting us to speak. As you know, my name's Jessica and I'm joined by my colleague Bea. Today we're going to talk about THET's principles of partnership. I'll give a first brief introduction to THET and the health partnership model, and then I'll talk through principles of partnership, providing a few case studies and tools that may be useful for you to further explore. And as you know, there'll be time at the end where Bea and I can answer any questions you may have. So let's go next slide, Bea, and the next slide as well, actually. So THET is a global health NGO which has been working in global health arena for over 30 years, supporting the training and development of health workforce and strengthening of health systems in low and middle income countries. Since 2011, we have been managing the agent of UK's largest health partnership program. We have three main strands of work: our country programs work, our grant management work, and our policy and learning work. Our programs and grant management work aim to support health partnerships between UK organisations. These might be UK hospitals, NHS Foundation trusts, royal colleges, academic institutions, and their counterparts in lower and middle income countries, which work to improve quality of health services by training health workers. Next slide, please, Bea. For our country programs team, we currently have offices in 6 countries in Africa and Asia. These are Zambia, Tanzania, Uganda, Myanmar, Somaliland, and Ethiopia, all which worked in partnership with various strategic partners, such as Ministry of Health, to strengthen health systems. Next slide, please, Bea. For our grant management work, THET are fund managers for several programs. In 2010, the UK government announced funding for a new program which would fund institutional partnerships between UK health institutions and their counterparts in lower and middle income countries. This was called the Health Partnership Scheme. From 2011 to 2019, through this funding, partnerships were formed and 269 projects delivered. Over 2,000 NHS staff volunteered overseas and trained more than 93,000 health workers across 31 countries in Africa and Asia. A significant majority of the lower middle income health workers who received this training have gone on to train others. That has now recently been awarded management of a successor to this Health Partnership Scheme programme, the UK Health Partnerships for Health Systems, which will be launched later this year and is focusing on strengthening health systems priorities identified by national stakeholders. Next slide, please, Bea. Other ongoing programmes include the Johnson & Johnson Africa Grants Programme, which is now in its 4th round. which funds health partnerships projects working on community health and surgery and anesthesia in sub-Saharan Africa. In recent years, Johnson & Johnson have narrowed their focus to essential surgery and anesthesia for mothers and children. So that's what this current program is focusing on. And if you click through B, the Commonwealth Partnerships for Antimicrobial Stewardship Fund is managed through partnership between THET and the Commonwealth Pharmaceutical Association. The scheme is funded by UK aid from the Department of Health and Social Care and is part of a wider commitment by the department to spend 245 million of UK aid to support lower and middle income countries to enhance surveillance of AMR by 2021 through the Fleming Fund. 6 projects are being funded through the programs in Ghana, Uganda, Zambia, and Tanzania, with the aim of strengthening AMS and IPC systems in line with national priorities. Next slide, please, B. Our policy and learning work draws on insights we gain through our programs work and our grants management work. We aim to continuously learn from these health partnerships. The activities of this work are, just to mention here, champion the contribution of health workers to the development of society, engaging and challenging UK government policy, advocating for best practice in global health, championing the health partnership model, and publishing policy papers. So now the health partnership model. Next slide, please. So all of the work which THET does is based around the partnership model and health partnerships. A health partnership is a partnership formed between a UK health institution, like I mentioned before, so either a hospital, a trust, health education facility, or a university, and the counterpart overseas. Partnerships may involve 2 or more partners, but they must be between institutions rather than just individuals, although they may be formed as a result of personal connections. The aim of these partnerships is to deliver health worker training and peer-to-peer support through utilizing the skills and experience of each organization. Partners co-develop programs that address organizational and national priorities. The partnerships themselves are generally long-term and sustainable, while the projects which they deliver are discrete and tailored to specific identified needs. The aim of all projects is sustainable impact and mutual benefit. So on the next slide, here we wanted to show a visualization of the partnership model and the role of THET and the donor within this model and process. So here you can see first the overseas institutions and the UK institutions identify the need and establish the partnership, then apply to THET for funding, and THET receives the funding from the UK Department of International Development in this example, and THET provides grants to the partnership to work together to deliver those activities. Next slide, please. So one of THET's main functions is to support the partnerships themselves beyond just the projects that we fund. It's not just enough to have a strong project. What we need is have a meaningful, long-lasting, sustainable change. It's partnerships that survive beyond just the funding cycle. Partnerships are real relationships between organizations which share the same principles and aims. The principle of partnerships, which you can see here on this slide, are what we think to be the key ingredients to a strong, effective, and equitable partnership. The principles were developed in conjunction with our southern and northern partners. These principles of partnerships, or we call them POPs, are to help improve the quality of partnerships approach and represent a hallmark of good practice. They also serve as tools and practical resources for both established and new partnerships. So as you can see, there are 8 POPs, all of which can be found on our website, along with tools and practical resources and case studies examples of how partnerships have achieved these POPs. I'll just talk you through a few of them now, highlighting a few examples of partnerships that we think have presented and reflected these well. So on the next slide, we're first going to look at strategic. This principle is outlined by hallmarks of good practice, which you can also see on the slide there to the right. Hallmarks of good practice are indicators which partnerships need to meet to be able to reflect the relevant principle. For example, if it is important for partnerships to have a clear rationale represented by a formal agreement between the two of them, such as a memorandum of understanding. One example of good practice is the NHS Highland and partners in Ghana. So on the next slide. This partnership is working to reduce health harm caused by alcohol. A needs assessment, which partners make, has the potential to be a dusty document produced with good intentions and then forgotten about. This partnership, however, uses the needs assessment as a process which is continuous and ongoing and evolving over time. This partnership identified the need by talking to people who were affected by the project. To do this, members of the UK team went to Ghana, met with a wide range of stakeholders to hear perspectives and opinions. By engaging with local stakeholders from the beginning, the partnership helped to establish local ownership and understand appropriateness for the project, and establish communication channels between the stakeholders. Next slide, please. The next principle is harmonized and aligned. This includes partnerships whose aims and objectives are clearly linked to an identifiable need. Their goals are built on and complement institutions' broader strategic plan, and there is a good buy-in from senior management, and where possible, there is collaboration with other organizations working on similar issues. Some of the most successful partnerships we find are ones that really try and engage with the Ministry of Health in the country in which they are working, along with other partnerships and organizations working in the same space. All too often, there is a duplication in work because people don't share learning or explore properly what other ways people are working. So a good example of this one is the Royal College of General Practitioners in partnership with the Ministry of Health in Sierra Leone. On the next slide, please, Bea. They set out with the aim of increasing the capacity of primary care workers to manage NCDs in rural areas of Sierra Leone. They originally partnered with the Ministry of Health and formed good relations with people working within the ministry. Then there was the election, and those who they were working with were replaced by others. They quite easily could have continued on with the project without trying to build new relationships, but instead they waited patiently and began rebuilding relationships with new people working in the ministry. This is quite a big risk for them because it meant huge delays to their project and missing targets, etc. But what has now meant that the Ministry of Health has signed off the training manual that they developed in collaboration with others, and is now the possibility of rolling out the training across the country rather than just having it focus on one region that they originally planned on targeting. Working with the Ministry of Health and ensuring that their work was aligned with national priorities has meant that they are eventually going to have a much bigger impact. The next principle is effective and sustainable. So partnerships that are effective and sustainable involve a large range of stakeholders and ensure continuity and local ownership. This often can involve the train-the-trainer approach, ensuring that knowledge is cascaded down. Good example of a partnership that has shown this is the Royal College of Pediatrics and Child Health and the partnership of Olajuwon Hospital in Freetown, Sierra Leone. This project aimed to train pediatric staff to deliver better quality inpatient and outpatient care to neonates, infants, and children. THET funded them for 2 years between 2015 and 2017, and then visited their project again in 2018 to see how they were getting on. The scale up and sustainability that we found was truly amazing. Since the end of the project, they have scaled up and are now training nurses in 13 hospitals across Sierra Leone. 6 UK volunteers pair with 6 of the originally trained nurses, so 3 pairs in the north and 3 in the south, and travel to hospitals in the region where they are based and train nurses there to be trainers. They then support these newly trained trainers to deliver training to both nurses and other health workers in the hospital where they are based. The aim now is that the UK volunteers can scale back and Sierra Leonean nurses continue training independently. Part of what made this project so effective is the huge amount of data that they collected on patient outcomes. This data showed the impact their training was having. They shared this with the Ministry of Health, got great buy-in from the Ministry of Health, and then this allowed them to scale up so effectively. The next principle is flexible, resourceful, and innovative. This is reflected in partnerships who are responsive and adaptive to changing needs. Often partnerships are working in challenging environments where change is frequent and unpredictable. So they need to be able to overcome these challenges in a flexible and sometimes innovative way. One example partnership that has shown this is the Royal College of Obstetricians and Gynecologists in partnership with Kitovu Regional Referral Hospital and Masaka Regional Referral Hospital. The partnership changed the way they worked in order to overcome challenges. This partnership, which trains midwives, nurses, obs and gynae professionals in emergency obstetric care. The training requires 3 days to complete, and to be successful needs a critical mass of people to be trained. This then meant that a large number of people would be taken off the ward for a large period of time, so these 3 days. Training is more difficult because there's more people, and the time between the pre and post testing is often too long, so there's a large amount of knowledge and not enough time to know it. And there would be severe shortage of staff on the wards. The partnership created a new approach to overcome this challenge, which split people into smaller groups and ensured more days of training over a longer period of time. This meant that less people were absent from the ward at one time, and there were smaller groups doing the training, so more people had a go at practical activities. There is now more time for each new skill to be taught for people and for them to practice them. From this change, they really saw a significant change in retention of knowledge amongst the trainees. Although this did mean that the training was more expensive, because they had to deliver more sessions, they felt that they meant the newly trained lead trainers would have more experience of delivering training. This worked because they listened to the local needs, what didn't happen last time, and they tailored their response to these needs. So though this didn't use new technologies per se, which is what most people automatically think when you think of innovation, this innovative way of training did show positive results. So the final POP I'm going to touch on today is committed to joint learning. This is reflected in partnerships who develop a culture of learning and build monitoring and evaluations collaboratively so they can identify what has worked and not worked well. One example of this is the University of York and Zomba Mental Health Services Partnership, which works to strengthen the system of community mental health in Zomba District, Malawi. This is a good example because the partnership has made sure to ask questions to all associated stakeholders to involve them in the project from the beginning and to initiate joint interest in the development of this project. When the overseas partner noticed some practical difficulties with the speed in which monitoring and evaluation data gathered was slowing down, the partners asked managers to help health surveillance assistants to prioritize the mental health intervention, work within the context of their own other work, and the momentum picked up. The partners listened and respected to each other's views and learned from difficulties to make these necessary changes to the project. Next slide, please, B. So we know that stronger partnerships equal stronger projects. Throughout all the projects we fund, we work with partnerships to identify any weaknesses in their partnership or areas where they could strengthen. This can either be done through informal discussions between partners or more formally. THET has developed a tool for partnerships to do a self-assessment of their partnership. This is called a partnership health check, which you can see on the slide here. This is available on our website, and it's a self-assessment, so it comes up as an Excel document, and you can click through and do your own score. Once partnerships have identified areas where their partnership would like to strengthen, we encourage them to think about ways that they do this, referring to the hallmarks like I mentioned earlier, and come up with goals which they can work together throughout the course of their projects and beyond, we hope. These goals are reviewed on a quarterly or 6-monthly basis, with progress being discussed during meetings. We do encourage partnerships who are not working on THET projects to also consistently think about how their partnership can be strengthened and continue to grow. Next slide, please, B. So more information on everything I've mentioned and the toolkit I just showed can be found on our website. So thank you very much. I'll stop there, and B and I welcome any questions that you have.
Thank you very much, Jessica. Thank you very much, B. Yeah, lots to think about there within your 8 principles, as well as the really helpful rooting of how THET came to learn these things and how THET came to develop these principles. So yeah, I will throw it open to the group. If you have a question, just like usual, feel free to type it into the chat, and we can read that out for B and Jessica and for others maybe on the call to address. Otherwise, you're very welcome also to signal that you'd like to ask a question, and then you can open your video and we can all see your face as you ask your question as well. So thanks very much. And as we're getting ready, I think my first question is there seemed to be quite a bit of emphasis on this idea of needs assessment and community assessment, thinking about how projects are being designed and monitored, what they're being learned. Can you say a little bit more about that process of needs assessment and how that weaves its way through the 8 principles?
Yeah, sure. So we always encourage every partnership before they start implementing a project to do some scoping on the ground to find out what it is that the in-country partners actually want and what the need of the population is. So we find that if everything is led by the partner on the ground, it's actually wanted, and the results end up being far more sustainable rather than a UK partner going in and say, we've got this expertise, this is what we can do. We always want projects to go the other way. We also always try and ensure that partnerships think about what other partners are what other development partners are doing in the area, so there's not duplication of effort, and I suppose that sits within the harmonised and aligned principle. At the moment, we are putting strong emphasis in all of our new programs that we're doing on ensuring that there's alignment with local and national plans. So in this new program, which we're about to launch, the UK Partnerships for Health Systems program, which is a DFID funded program, we're ourselves are carrying out scoping exercises on the ground so that we can ensure that the priorities that we put forward in the call are aligned with those of the Ministry of Health and the national government, because we find again that if we've got support from the Ministry of Health, the impact of the programme is much more likely to be sustainable going forward. Jess, is there anything you'd like to add?
I don't think so. I think you covered it, B.
Does that answer your question, please?
That's a good start. Yeah, definitely. We have had one question from the chat asking just if you could review again where THET's name comes from. I think that was the very beginning, but what does THET stand for, and how does it connect to what you do now?
So it stands for the Tropical Health and Education Trust. And B, you can maybe speak better to this, but it comes from Sir Eldred, who started it over 30 years ago. But from his work, so I don't know if you want to go on into it.
Yeah, so Sir Eldred Perry spent much of his life teaching in medical universities in various countries in Africa. So he taught in Nigeria and Ghana and Ethiopia, and he came back to the UK. I think he did 5 years or so in each of these countries, and he came back and he realised that there was so much wasted potential, I suppose, and that partnerships between UK and LMICs could kind of bridge the gap almost, because I think he found that there was so much more that he wanted to do in setting up medical universities and things that I don't know, but it needed to be the capacity on the ground that took that forward.
Thank you. And as I think as you saw at the beginning of your deck, a lot of your funding comes from the National International Development Program, DFID, in the UK, but also you have partnerships with corporations as well that provide some of these grants, or you administer on their behalf. Is that correct?
Yes. So we're currently running the Johnson & Johnson Africa Grants Programme, and then the Department for Health. So I don't know how much you know about UK politics, but Boris Johnson, our Prime Minister, is very keen on making using other departments to distribute our ODA. So the Department of Health is starting to play a larger role in doing that. So we're now getting more funding through other departments rather than just the Department of International Development.
Thank you. Thank you. Great. So if I'm thinking about and thank you, Niti, for broadcasting that. We've got principle 7, and so my question is more to the group, and we can have Bea and Jessica around to comment on this as well. But number 7 was about being flexible, resourceful, and innovative. And so my question to the group is, obviously the context of our work in Cleft Care has changed with the pandemic that we've been talking about every day. What are some elements of flexibility that you're either requiring to discuss, with the funding that you have, or that you'd like to see in terms of what's changed in the way that we deliver cleft care, and specifically comprehensive cleft care in the midst of this pandemic? Would anyone like to comment from the participants? What are you seeing in terms of flexibility that's either required or that you're seeing already that's changing in terms of how funding sources from places like Toronto or the UK or the United States, and then what you're seeing on the ground in terms of some of those needs? I'll invite you not to be shy.
So I wonder, from our point of view, it would be useful.
It would be really useful to know. You're bailing people out, Bea, but that's fine. I'm still coming back. Someone's going to tell us a little bit about how things are changing on the ground, because we know they are. But yes, please, Bea, tell us a little bit more about what your perspective on number 7 is.
It would be great just to know what people's experiences are of different kinds of funders, because from our point of view, we know that if we get government funding, it's much harder to be flexible. But if we get funding from, say, Johnson & Johnson, they're much more amenable to people saying, oh, well, we're meant to be doing a project on surgery, but we've got this pandemic. Can we move some of the money across to target that? Have people had experiences of that with different funders?
Thank you, Bea. As we're waiting for people to gather up their courage or their idea, one example that just really struck me a couple of weeks ago from one of our partners in Ethiopia was suggesting, just even within the pandemic restrictions. So, a huge barrier to accessing comprehensive cleft care can be transportation. And it'll be the same, obviously, in many of your partnerships in the places that you work as well. But one example that stuck with me was, traditionally you could get in a taxi with 15 other people. There'd be a certain cost, and that would take you to the clinic or to the hospital, and that could be reimbursed, or whatever the scheme is, that could work. Now, of course, with restrictions with the pandemic, you're going from having the costs that could be shared among 15 different passengers down to the cost having to be shared by 3. And so that can have a huge impact on our budgets, on the way we're thinking about care, even if people are able to leave their house and come to a hospital or come to a clinic. So that's been helpful for me, representing a funding organization, thinking through, wow, how do we think through the budgets and the plans that we had? And how can we be flexible and innovative in responding to a brand new situation, where transportation costs, either transportation is very difficult, or even if it's available, that's become much more costly than it was just 2 months ago. Does anyone else have another example of things that are changing in terms of how they're delivering care? And I'm going to pick on you, Dr. Giant, if you don't say anything soon. In Bangalore, Dr. Giant, how are things changing for you in terms of the context for comprehensive cleft care in the midst of this pandemic?
Well, Hugh, you put me in a tight spot. Well, I'll take that. Now, with the COVID coming into the picture, there has been a demand from the hospital, which is our partners, that we provide the PPEs for all the surgeries and the comprehensive care. Likewise, the colleagues, the anesthetists and the OT staff also would want COVID testing to be performed in view of the health of all concerned. So that's out of peer pressure that we'll have to do COVID testing before we push the patients into the operation theaters. And this is where the logistics of the budget are being challenged. And there are instances where patients do want to come and get operated, and they too are seeking help for some sort of an transportation which can be they would want to take a taxi. Now Uber or other services have just begun in the city, and public transportation is not commonly available in most of the Indian cities. So these are the challenges that we are coming up with in terms of having to manage not just getting the patients to have a convincing mindset when they come to the hospital, but also to deal with the challenges financially when it comes up to the hospital environment, both from the hospital side and the colleagues who have justifiably requested for PPEs and COVID testings to be performed, given the elective nature of the Cleft work. So these are the constraints under which we'll have to work, and obviously we'll have to sit together with everybody, have discussions, and see how much of the provisions we can make for from the existing budget, given that the number of cases are going to be down this year. Meaning the secondary cases might not come up, or the primary cases might delay coming up. So therefore, looking at these scenarios, you can expend some from your existing budget pool, whereas for the others, you might have to seek out new support from Rotary organizations or some other organizations, or from your existing parts.
Thank you. Thank you, Dr. Giant. That's a very helpful response. And that really is a little bit of where the rubber hits the road in these partnerships when we're talking about money. When we're talking about budgets, when we're talking about having to rethink the way we expected to deliver a certain service in light of this requirement of providing, or at least having access to PPE or personal protective equipment in order to perform some of these cleft procedures. Bea and Jessica, what would you draw in terms of how budgets are impacted in these principles of partnership? Where have you seen them activated effectively?
Well, I think I'll let Bea speak after, but now I think we're really, definitely pulling on the principle 7 of being flexible, resourceful, and innovative, because a lot of our partnerships now are having to think about how can they adapt to what the projects and activities they're doing now, how they can maybe within the same scope. So say if they're doing infection prevention control activities, how they're having to maybe adapt those slightly to be more not more focused on coronavirus, but still incorporating IPC, but really then thinking about immediate support to health workers. So one of our examples is that, and Bea can maybe speak more to this, but we're seeing partnerships who have focused on developing hand rub, antibacterial hand rub, how they're scaling that up so they can have they can provide better protection to health workers specifically during this pandemic. So what they're having to really be flexible with their resources and time, and thinking about their budgets and how they can work together, both from the UK, both UK and overseas partners experiencing this pandemic, to do what they can on the ground with the links that they have and the resources they have available to respond. Yeah.
Thanks, Jessica.
Yeah, I think you're right, Jess, in that they need to think about the resources that they've got available at hand. So we launched a program called the Health Worker Action Fund, which one of the aims of it was to help support the in-country partners in acquiring PPE, and there were a couple of applications put in where people were planning on buying PPE in the UK and shipping it over, and you think, well, it's a waste of resources when presumably there are some resources that can be utilised on the ground instead. So we had to be quite brutal, really, in what we thought was value for money in terms of is it value for money shipping things over from the UK when they can be made at a much lower cost?
Sure. So thank you, Bea. So definitely this idea that just because something's available and you can offer it, that doesn't mean that doesn't make a partnership in and of itself. And I think back to your initial point about thinking about what's that expertise, what's the capacity, what are the ideas on the ground, and starting from there, as opposed to, hey, we have this free thing, take it, and that's how we're showing we're a good partner. I think that some of these principles turn that a bit on its head. I think there's a couple questions in the chat, which is great. Thank you for participating. Dr. Mehendel, who's also in the UK like you, asks, what are the lessons we can learn and apply to this pandemic from your experience in delivering and modifying projects, and especially with these big cataclysmic events like another pandemic or something that has to change a project rapidly? How do these principles of partnership sort of operate, and can you give us an example of how we can what we can learn about modifying projects on the fly?
Yeah, so I suppose the only real example that we have I have in recent memory is the Ebola epidemic in Sierra Leone. So we had a lot of projects working on the ground, and I thought it was really sad at the time, but a lot of the UK institutions decided that it was too risky to have their partners still out in Sierra Leone. So they brought all the UK volunteers back from Sierra Leone, apart from one partnership which stayed. And I think we need to, and I think this is what this pandemic has taught us as well, we need to appreciate the capacity that we have when we do things remotely. And I think it's going to change how we fund things in the future, in that it is possible to train people over Zoom. I know it's better for the environment as well. I mean, in the past, a lot of projects just fly people out, and I think that this is going to change how we work overseas. I'm sorry, that doesn't really answer your question, but Jess, do you have anything to add?
No, I don't think so. I think what you said, be about, I think for many areas of work, it's really good to have to think about, and a big focus that for us now with THET is thinking about digital resources and supporting partnerships with developing those and training through virtual platforms, and really thinking about how we can support that area, because that's what partners are focusing on now, especially, and trying to respond quickly to support their overseas partners.
And I think it's taught particularly us in the UK that we don't always know best. I mean, our response to the COVID-19 crisis has been terrible compared to how, say, Uganda's dealt with it. So it's us that can learn from our partners, really, not always the other way around.
And I think you've touched upon one of the main ways. Obviously, there's a couple of things that are there. I mean, the first is that this is not just about the funders, in Canada, for example, kind of cooking up new ideas and saying, this is what we're going to do now. But also, as we think about, how to do things more safely, more sustainably, more cost effectively, potentially, is this idea of virtual. So Dr. Bowen Sip in Thailand, his comment is, we need to adapt digital resources and training of local health personnel and families to take care of patients. And obviously there's cost to that, as Sylvia Torres mentions. A key element that we've been wrestling with, and we keep beating the drum for, is the sense of that Wi-Fi is not universal. That telemedicine, telehealth strategies are so far, at least in my discussions, are limited in their effectiveness in the most vulnerable communities, in villages that don't have access to steady Wi-Fi or even steady cell phone service. Are we leaving them behind right now? And so this is something that I'm not sure if you want to comment upon, but there's others who are commenting on this as well. I mean, this move to telemedicine sounds great, and obviously all of us today have been able to get on the call. How do these principles of partnership apply when we're thinking about the most vulnerable who potentially don't have access to some of these sources or resources?
Yeah, so we're actually at the moment going through a process of reevaluating these resources, and we are hoping to add in a gender equity and social inclusion principle, which we don't currently have. So yeah, keep your eyes out for that, which is coming in the next few weeks.
There's some appreciation, I think, in the comments from, the shout out for Uganda in particular, this idea that Dr. Mehendel and Debbie Sell also agrees, I think in the UK and other high-income countries, we should request training from our low and middle-income country partners about improving our pandemic responses. And obviously some of the big failures of some of the key funding organizations that are on this call, at least the countries in which we're located, I mean, those have been front and center in the news. You know, we have lots to learn. I'm going to throw this back out to the group now. So all, you know, many of us on this call in some way are connected either to a funding organization or to a local team implementing comprehensive cleft care or both. But if we look at these 8 principles that you're there, and even just the high level one, do you have examples of how in your experience effective partnership has been demonstrated? You know, is there something that you see on here and you say, aha, yeah, this is a strength that we've seen so far in this situation? Is there something there that the rest of us could learn from? So I'm looking for some examples. Either I'll start from the positive side. You know, what are some elements of partnership that you have found to be helpful within the cleft space? And maybe V or Jessica could weigh in on what we hear as well. But are there any things that come to mind as you listen through? And I mean, you went through number 1, 2, 3, and 7, and 8. So strategic, harmonized and aligned, effective and sustainable, flexible and innovative, and this idea of learning. But are there some examples that came to mind that might have some resources for us in this COVID era of ways that effective relationships between funding type countries and local teams have worked? I'm allowing the pause to drag out for a second. There's got to be some examples of ways that we're working well on this. And I'll get to Felicity's question in a second. I mean, one example that comes to mind, and we know we have some colleagues here from Chile, but I mean, we've been quite inspired in Toronto by the work, and I think that was in number 2, the principle harmonized and aligned. You mentioned this idea of getting buy-in from the Ministry of Health. So maybe one of my colleagues from Chile can weigh in, but this idea that how Chile has been able to have the Ministry of Health endorse some protocols around cleft, you know, where there were none, and in many countries still cleft as a non-communicable disease or disability, depending on how you look at it, you know, is not high on the agenda. Our colleagues in Chile have had some great success in allowing, in having the Ministry of Health sort of endorse sort of some key protocols that every person who's affected by cleft should have access to. And that was a result of really that hard work of working with the Ministry of Health to understand and to work through that partnership so that there is care available to many people. Dr. Yuri, did you have your hand up? Please, go ahead. In Bulgaria. I'm not sure we can hear you, Dr. Yuri.
Can you hear me now?
We got you now, Dr. Yuri. Please go ahead.
Sorry.
From
I'm
Plovdiv.
sorry that I'm late, but I'm just very interested in this analysis of what are the good tools for a good partnership. And we are maybe a good example because we have been, our organization, Allies, have more than 23 years of existence. And as we have shown to many people that we are trying to be sustainable and serious in the multidisciplinary care of cleft lip and palate patients, we succeed to have the time and the experience to find you and other organization that has helped us to improve the situation in our country, in which surgery is not prohibited, but not very well sustained, supported by the government, but not other type of medical provision and psychological help is available in our country. So it's the time is showing that we have been lucky to find that there is a big group in the world that care about that. So the principle of when we have been visited by you, it was very helpful to see where are our weakness, where are our not very professional type of attempt to improve the situation. So it was been crucial to have this external view that we are not able to see when we are working inside the country. So for me, it's very good to share the experience and to take the good practices. And finally, the problems are more or less similar in each country in the world, and we can take the recipes. When you have something that is missing, there is some answers that are already invented. And of course, the goals could be very high, and the goals could be very much realistic of what we can achieve with the time, the staff that we have. So it's for me, all this very well structured knowledge that you gave us was very useful when we make the training. So of course we understand what we need, but it's good to have these rules and to go very systematically and to achieve each point as much seriously and professionally as possible.
Thank you, Dr. Yuri. That's very helpful. So, I mean, really activating, I'm hearing you activating, number one, this idea of that principles of partnership are strategic, you know, that there is a sense of a jointly agreed framework where you can assess how you're doing, but also back to 8, you know, this commitment to joint learning, that there are standards, there's learning, there's things that can be happening elsewhere. And one thing I really appreciate about THET's approach is that they've been pushing us today towards that idea of self-assessment, that accountability and assessment is not just the responsibility, or not even at all, you know, only the funder coming in and saying, how are you doing, you know, what's there, but that sense of, hey, there's things we can all learn in terms of how we're learning about how to implement these projects, and there's ways that each of us can continue to improve. I think that those kinds of questions that is pushing around self-assessment, as you're mentioning, Yuri, as well, you know, how can we compare to what's happening elsewhere, and what does that mean for us in terms of our plans for the future? I think that's a very helpful piece as well, so thank you.
Thank you.
Felicity has asked another question, you know, the sense of a common template. What kinds of templates do you use in terms of community assessment or needs assessment? Are these each one custom made, you know, for the context, or are there some general principles that are in place for all the projects that funds in terms of setting this framework for a good partnership?
Yeah, so I think it depends on the different partnerships in terms of what needs. So sometimes if it's one of the institutions that's part of the partnership is a university or a research institution, they might have more kind of specific way that they want to carry out the needs assessment. But in terms of tools or things to think about with needs assessment that you could look at further, so on our website, which is THET.org, if you go to the principles of partnership, and then under strategic, if you go to the hallmark, which is about identifying the needs, there's a few tools there and guides about how the different ways that organizations have used certain templates to assess needs and resources around that, and also a case study, which might be helpful to look at further. I don't know if B, you wanted to say anything else further on that.
Sorry, just to add, so it looks like Felicity says not so much the template, but also the findings of the needs assessment. And I think that that's something which not just the health partnership community, but development partners in general really struggle with. There's kind of a feeling of, oh, this is our work, we're not sharing it with others. And I think that's a mentality and an attitude which we that are specifically working to change at the moment. So in our new program, there'll be all of the partnerships who are involved in that will have to meet on an annual basis to discuss what they're working on, what they found, share all their learning, so that it's not just for them, but it's for the good of everybody working in that country. So at the moment, there's not necessarily a place where all of that information is stored, but we're hoping with, at least with the health partnerships that we support, there will be. But we always encourage people to publish all of their findings as well. I think there's just such a wealth of information out there, which is always the best place to start. And I think that ministries of health are getting much better at documenting all of this information as well, and putting in place national plans, which are kind of obviously on a 5-year basis, but I always think that they're the best place for our partnerships to start when they're thinking about working in a country.
Thank you. Yeah, very good. And so we see back to just the conversation about Chile. Marina, a former facilitator for this group as well, has just mentioned that, you know, that they have had success since 2004. Cleft is now considered a high impact malformation, and patients born with a cleft have the right to care. And that's a long journey. And I think that goes back to your principle 3, you know, effective and sustainable, that these aren't just two-way relationships, you know, funder and field partner and back and forth, but that idea of sustainability requiring that level of advocacy, requiring that level of transparency, publishing, you know, releasing documents, talking about impact, so that the Ministry of Health in particular, you know, can be brought into the conversation, to now to the point where in Chile, you know, every patient has a right to care, and that's beyond just availability of funding. So, you know, some examples of how some of these principal partnerships can lead to some longer term solutions. I think there is something else in the thing. Yes, a response to that. That sounds like a great approach. All right, we're getting close to the end of our hour. I'll just say, I guess, thank you to Bea and Jessica, and you know, we would like to continue this conversation. So Niti, if you would go to the next slide. I think there's lots to talk about here, and again, I think this is the beginning of a conversation around, you know, in light of this pandemic, how do we think of ourselves in the Cleft world as, you know, trying to learn from the best learning of development organizations? You know, this is a unique, unprecedented situation. I know which adjective you're getting tired of, but this is, you know, this is serious stuff. And the idea that we can do more if we're grounding our partnerships in some of these principles, if we're learning from the best practices, if we're trying even amongst NGOs of sparking each other to do better in terms of how we respond to realities on the ground, and how we demonstrate that true effective partnerships. I think that this is an opportunity for us to move forward. So we'd love you to continue the conversation. There is a Slack platform where we'll be posting the video. If there are colleagues who missed it, who you think might want to think through there, and I think also some conversation, are there organizations, and I think even for Transforming Faces, you know, an organization that I help to lead, you know, if there are some of our partners that would like to do this self-assessment, I think I'm opening it up. I think it'd be wonderful. Our team of program managers would love to walk through, you know, how are we doing in terms of our own partnerships, where can we grow, and even to be able to start sharing some of those results. So thank you to Bea and Jessica. Coming up next, we will continue this kind of learning, trying to demonstrate a principal partnership number 8, learning. What's up next? Well, we have had a lot of interest in our speech therapy webinars of late. So coming up next, we want to continue to activate that. We've got 3 experts. We've got Dr. Suraj from Chennai. We've got Dr. Olusano from Nigeria, and we've got Karen Goldschmidt from Santiago de Chile. And they're going to share some of what they've been learning in terms of a panel discussion on speech therapy amidst COVID-19. So you won't want to miss that. That's going to be on June 25th. At the regular time, so 8 o'clock in Toronto, but elsewhere across the world. And this is really going to be a fantastic time for us to compare notes, to dig into the insights of these experts so far, but also to hear from everybody else on this call. What are you learning? Where are the pinch points? What can we be focusing on to make sure that more and more patients are having access to the care that they require? And then going further, even going back to Bea and Jessica's comments around publishing. Dr. Christy McKinney, who's a great friend to Cleft research overall out of Seattle, has agreed to lead a webinar on planning a research project. How can we continue to learn in light of the COVID-19 crisis, and how do we learn to document better some of the things that we're experiencing? So that's coming up in the summer, at least in Toronto summer, July 22nd. So keep this on your calendar, Google Calendar invite to follow. And if at any time you'd like to learn more, have questions, you can send us an email at info cleftcircle.org, and we'd love to respond to that. So great, thanks to everybody. Feel free if you want to say something in the chat. We'll stick around for a couple of minutes, but we do want to respect the hour. So again, thank you to our colleagues at THET for offering this really stimulating push to think more deeply about how we're doing in this time of so much transition.